Welcome back, everyone, to another deep dive. And I have to say, this is a pretty massive milestone for you.
Oh, absolutely. Huge milestone.
Yeah, because if you are tuning in right now, you have officially made it to episode 11 of 11. This is the finale of our deep dive series covering the Cert Prep Academy NNAAP syllabus.
Which means if you've been with us from the start, you have literally covered everything on the written exam blueprint.
Everything. From vital signs to dementia care. And look, I just want to take a second to say, acknowledge how much hard work you've put in. Preparing for this exam is a massive undertaking.
It really is. It takes so much dedication. You should be incredibly proud of yourself for sticking with it.
100%. So for this final deep dive, we are bringing it all home. We're looking at the core of what you do. The topic today is the role of the nurse aide, specifically focusing on scope of practice, documentation, and professionalism.
And just to give you some context on why this is our finale, if you look at the NNAAP exam outline, this category is huge.
Right. It's a huge chunk of the test.
Exactly. I mean, communication alone is 8%, client rights is 7%, legal and ethical behavior is 3%. And functioning as a member of the healthcare team is another 8%.
So you do the math on that, and we're talking about over a quarter of the entire written exam.
Yeah, over 25% just on these concepts.
Which is wild. So today, we are your study partners. We're going to look at a massive stack of source material. Specifically, we're going to tackle the trickiest scenarios, break down the wrong answers, figure out those memory aids, and make sure you are totally bulletproof for test day.
I love that. Let's make you bulletproof.
Right. So let's just unpack this. Section 1, we are starting with the absolute blueprint of your job, which is your scope of practice.
Because before you can be a great CNA, you really have to know exactly where your boundaries are.
Right. It's the fundamental question of, what am I actually allowed to do legally? So let's look at the core duties. The source material brings up these scenarios where you have a primary duty, but then the exam gives you these distractors that they look incredibly tempting.
Oh, they totally do.
Yeah.
They prey on your desire to be helpful.
Right. Things like administering medications or performing wound assessments or making independent care plan decisions.
Right. And to be crystal clear, the primary role of the CNA is assisting with activities of daily living. ADLs.
Bathing, dressing, grooming, that stuff.
Exactly. Toileting, mobility, working strictly under licensed nursing staff. But let's talk about why those distractors are always the wrong answer. Take wound dressing changes, for example.
Yeah, let's play devil's advocate here. Because honestly, if you've been working on a busy floor for a few months, you've probably watched a nurse change a dressing like 100 times.
Right. You stand right there and watch them do it.
Yeah. Yeah, and it looks mechanically simple. You take the old tape off, remove the gross gauze, put the new sterile pad on, and tape it up. If the nurse is totally slammed, why can't I just step in and do it? I mean, I know how to use medical tape.
It's so tempting. You just want to alleviate the nurse's burden. But this is a hard, non-negotiable line in the sand.
Because it's not just about the tape, is it?
No, not at all. When a nurse changes a dressing, they aren't just doing arts and crafts. They are performing a clinical assessment.
Ah, the assessment piece.
Yes. They're looking closely at the wound bed. They're evaluating for, subtle signs of infection, changes in the color of the drainage, the temperature of the tissue. They're measuring the margins to see if it's healing.
Wow, okay.
Right? A nurse aide is simply not trained, nor are they legally licensed to perform that level of clinical assessment.
Yeah.
So if you do it independently, you are completely removing clinical oversight from a vulnerable wound.
That makes so much sense. It's the evaluation, not the mechanical action.
Precisely. And that exact same logic applies to administering medications.
Because giving someone a pill looks super easy.
Right, you're just handing them a tiny paper cup.
Yeah.
But administering meds requires rigorous pharmacology training. You need to know drug interactions, side effects, contraindications.
Which you don't have the license for.
Exactly. And the care plan distractor. Making independent decisions about the care plan is a binding legal process formulated by the RN, the physician, the whole interdisciplinary team. You follow it, you provide data for it, but you don't make executive decisions to change it.
I always like to use this analogy. Scope of practice is like having a driver's license versus a pilot's license.
Oh, that's a good one.
Right. Like you train, you pass your test, you get your driver's license. You are fully licensed to drive that car down the highway. That's your ADLs.
Right.
But if you suddenly decide you want to walk onto the hospital tarmac and fly the medevac helicopter, which would be, administering meds or diagnosing you, breaking the law.
Even if you've watched the pilot do it 100 times from the passenger seat.
Exactly. You don't have the license for the helicopter. If you touch those controls, you are a danger to everyone.
I love that. Keep your hands on the steering wheel of the car. And the material reinforces this with invasive procedures too, like inserting a urinary catheter.
Oh, yeah, because you're literally entering the body.
Exactly. It's an invasive, highly sterile procedure. It carries a massive risk of introducing a healthcare-associated infection, a CAUTI.
The catheter-associated urinary tract infection.
Right. If you break the sterile field even slightly, you could introduce bacteria that leads to sepsis. It is strictly a nursing task.
So the primary role is crystal clear, supporting the nursing staff, doing the ADLs, and this is one of those scope of practice things that Cert Prep Academy flags as high priority, by the way. Knowing your lane, you are the eyes, the ears, and the hands working under supervision.
Yes. That is a profound responsibility all on its own.
It really is. But let's talk about the gray areas, because the real world is messy.
Oh, very messy.
Let's talk about handling the unknown and delegation. The material sets up this scenario. What happens when a nurse delegates a task to you, but you aren't sure about it or you haven't done it before?
The only safe professional response is to inform the nurse, ask for clarification, or ask for guidance and reassignment.
Okay, but I have to push back here. Let's talk about human psychology on a busy floor.
Okay, let's hear it.
If I am a new CNA and the charge nurse is running around, alarms are going off, they look incredibly stressed out, isn't it super annoying to keep stopping them to ask questions?
I mean, you feel like an annoyance, sure.
Right. My human instinct is just to figure it out on my own so I don't look incompetent or so I don't become a burden to the team. Let me just do the task so she doesn't yell at me.
That is such a real, visceral fear. It really is. But it's exactly the fear that leads to catastrophic mistakes.
Really?
Absolutely. You have to rewrite your internal script here. Patient safety always, always trumps your desire to look perfectly competent.
Wow.
It always trumps your fear of annoying the nurse. Because think about the alternative.
If I mess it up.
Right. If you perform a task you aren't sure about just to save face, and you harm a patient, the consequences are disastrous. The nurse would much rather you take 30 seconds to ask a clarifying question than spend 3 hours doing incident reports and managing a medical emergency, because you guessed.
Yeah, that's a very fair point. What about just flat out refusing? Like, nope, never done it, not doing it.
Well, refusing without a dialogue is highly unprofessional. It stops you from learning. The task might actually be in your scope, you just need a quick refresher.
Yeah.
The key is asking for guidance, not just building a brick wall.
Okay, here's a distractor I see a lot, the ask your buddy approach. The exam will give an option like, ask another nurse aide if they've done it before. If the nurse is busy, I'll just ask Sarah down the hall.
Ah, yes. Peer advice. The problem is peer advice is entirely informal and unregulated.
Right, because Sarah might be wrong.
Exactly. Just because Sarah did it once doesn't mean it's actually in your scope. Or maybe Sarah transferred from a state where the scope is slightly different. You simply cannot rely on peer folklore for clinical boundaries.
Always ask the supervising nurse.
Always.
And what about the secret handoff, where you just ask Sarah to go do the task for you and you don't tell the nurse?
Oh, that's a huge violation. It completely shatters the chain of command.
Because the nurse thinks you are doing it.
Right. The nurse assigned you that task based on their mental map of the unit's workflow. If you tap another aide on the shoulder and say, hey, can you do room 402 for me? And you don't inform the nurse, accountability goes out the window.
And if something goes wrong in 402, the nurse is coming to look for you.
Exactly. It's a massive liability.
Yeah.
And an even worse distractor is the one that suggests you just document that the task was completed, even though it wasn't, just to clear your list.
Oh, yikes. That's falsifying a legal document.
It's literal fraud,
Yeah, don't commit fraud on your Tuesday shift. Bad career move.
to say the least. So the pattern here, what the exam wants to drill into your head, is humility. Never guess. Acknowledge your boundaries and communicate constantly up that chain of command.
Which is actually a seamless transition into Section 2, the chain of command and navigating the healthcare team.
Perfect.
Because teamwork isn't just a corporate buzzword here, it's a legal structure. Your fundamental role is working under the supervision of the licensed nursing staff.
Right. You are the sensory organs of the team, gathering data, supporting the plan.
But let's look at the legal responsibilities in that teamwork. There's a scenario that asks about your core duty, and the correct answer is to follow the orders of the nurse and report changes. Simple enough. But there is a distractor that is a massive, fascinating trap.
To break it down.
The distractor says your duty is to perform all requested tasks without questioning safety.
Oh, wow. Yeah, that is a highly sophisticated trap.
Because theoretically, if a licensed professional tells you to do something, you should do it right. They're the boss. They have the license.
Generally, yes. You follow orders, but there is a massive caveat. If a nurse tells you to do something that you know is fundamentally unsafe, let's say they tell you to use a mechanical Hoyer lift to transfer a patient,
Okay.
but you know that specific lift has a broken hydraulic valve. Blindly following that unsafe order is actually illegal and unethical.
So the whole "I was just following orders" excuse doesn't hold up.
Not at all. Not in a court of law. Not before a licensing board. You are an independent moral agent. You're an advocate for the patient, not a mindless drone.
So what do you do?
If an order is clearly dangerous, you have a professional duty to respectfully push back, state the safety concern, and refuse to perform the dangerous act.
Which takes a lot of courage.
It does. But courage is a prerequisite for healthcare.
Teamwork means communication. It doesn't mean a dictatorship where safety gets ignored.
Exactly.
So communicating observations about the patient is obvious. But here is where this deep dive gets highly uncomfortable. Let's talk about dealing with colleague misconduct.
This is always a tough one.
Right, because nobody wants to deal with this. The material has a scenario. You witness another aide providing visibly poor, substandard care to a patient, maybe rough handling or just ignoring them. What is the appropriate action?
The only appropriate professional action is to report the concern to the supervisor or the nurse in charge.
But let's pause and really look at this. Because human nature makes this incredibly hard. Nobody wants to be a snitch. Nobody wants to feel like they are betraying a colleague that they have to share a break room with later.
Oh, absolutely.
Is it really my job to police my coworkers? Doesn't that just create a toxic environment?
It's a very common fear. The psychology of the workplace makes reporting a peer feel like a huge betrayal. But you have to completely shift your perspective on what loyalty means in that building.
How so?
Your primary loyalty, legally, ethically, and morally, is to the patient. It is not to your coworker. If you choose to stay silent to protect your buddy, you are effectively abandoning that patient to poor care. You become complicit in their suffering.
Oh, it's the truth.
Silence enables poor practice.
Okay, but what about the instinct to just handle it myself? Like confronting the other aide directly right there in front of the patient. Hey, stop doing that. You're being too rough.
Well, there's nuance here. Stopping immediate physical harm in an emergency is one thing. If someone is about to drop a patient, obviously step in.
Right, save the patient.
Exactly. But confronting a colleague about their general standard of care in front of a patient creates massive drama. It causes intense anxiety for the patient, who now feels trapped in the middle of a fight. It's deeply unprofessional.
And telling other staff members, but not the supervisor.
That's just gossiping. Gossiping in the break room doesn't solve the problem. It just breeds toxicity. The only professional channel is up to the supervisor.
Got it. Up the chain. Let's look at another classic scenario. You learn that a coworker has been sleeping during their night shifts.
A very, very common real-world issue.
Right. And the answer is to report the concern. But again, human nature says, hey, night shifts are brutal. They have a newborn at home. They're exhausted. Let them catch 20 minutes in the recliner. It's not a big deal.
But it is a massive deal. Sleeping on duty in a healthcare facility isn't just slacking off like it might be at a desk job. It directly compromises patient safety.
Because things can go wrong fast.
Exactly. If a patient tries to get out of bed and falls, or has a cardiac event, or their oxygen tubing comes off while that aide is asleep, the consequences can be fatal. You cannot ignore it.
You can't just wake them up and say, hey, don't do that again.
No, because confronting them privately might just make them defensive, and it doesn't officially address the safety risk to the unit. You have to report it.
And it's the exact same protocol if you witness a patient being treated disrespectfully, right? Verbal abuse, mocking.
Exactly the same. Whether it's poor physical care, sleeping, or verbal disrespect, the protocol does not change.
You can't just wait for the patient to complain.
No. Waiting for the patient to complain delays intervention. And think about the power dynamic. The patient might be too scared of retaliation or too confused by dementia to ever complain. You are their voice.
Which brings us directly into Section 3, the non-negotiables. Legal duties and abuse reporting. This is arguably the most serious high-stakes material you'll face.
It really is.
Let's talk about spotting and reporting suspected abuse. When you observe a patient with signs of abuse, the most appropriate action is to report it to the supervisor or nurse immediately.
I want to highlight the word immediately there. This is not something you write on a sticky note and mention in passing as you clock out.
Yeah.
Reporting suspected abuse is a mandatory, legally binding requirement.
Let's dissect the distractors because they sound almost noble if you don't know the law. One distractor suggests you should keep the information confidential to protect the patient's privacy.
Right, which sounds like you're being a good, discreet caregiver.
Yeah, like you're protecting them.
But it's entirely legally wrong. Confidentiality laws, like HIPAA, do not apply to hiding abuse. Keeping abuse a secret violates mandatory reporting laws and leaves the patient in imminent danger.
What about asking the patient directly? Hey, Mr. Smith, are you being abused by your son? Why shouldn't I just ask them to confirm it before I cause a big stir?
Asking directly can actually be incredibly dangerous for the patient. You have to understand the psychology of abuse. They might be terrified of retaliation.
Oh, so if they go back home?
Right, if you ask them, they might panic. Or they might feel pressured to lie to protect a family member, which creates a false narrative that ruins future official investigations. Plus, you aren't a trained forensic investigator.
You could ask a leading question.
Exactly, you could taint their testimony. Your job is just to observe the physical or behavioral signs and report them. The supervisor will initiate the proper legal protocols.
And documenting it in your personal notes but not telling anyone.
Worse than useless. It is negligent.
Yeah.
You've recognized a threat, documented it, and actively chosen to do nothing. Massive liability.
Okay, let's look at a highly specific scenario. You are bathing a patient and notice bruises that look distinctly like handprints on their arms. The patient is confused. The correct answer is to document what was observed objectively in the chart and report to the nurse immediately.
Yes.
But let's look at a distractor that I think is a huge modern exam trap. The distractor says, take a picture with a personal phone to show others.
Oh, man. Yes. This is crucial to break down.
Because I can see exactly why a well-meaning person would think that's a great idea. We live in a world of smartphones. You might think, I need proof so the supervisor believes me. I need to document this perfectly before it fades. So you pull out your phone.
It feels proactive.
Mm-hmm.
You feel like a detective gathering irrefutable evidence. But taking a photo of a patient with your personal cell phone is a catastrophic, multi-level violation.
It's a dual violation, isn't it?
It is. First, it is a massive health and privacy breach. You now have protected health information, an intimate image of a patient's injured body living on your personal device.
And that device probably syncs to the cloud.
Exactly. It might automatically sync to your personal cloud, meaning that image is now stored on servers you don't control. You might show it to your spouse. It is a complete loss of privacy.
I hadn't even thought about the cloud syncing. That's terrifying.
The digital trail is permanent. And second, it completely violates the legal chain of custody and facility protocols. Facilities have specific, highly secure procedures for documenting injuries legally.
Right, they have their own cameras.
Yes. If you use your personal phone, defense lawyers for the abuser could argue the photo was altered, effectively ruining the legal case, and you will definitively lose your job and your certification.
So no personal phones, ever. You document the facts objectively, bruising noted on bilateral upper arms, and tell the nurse. Period.
Period.
Let's look at another forensic clue. The material mentions a patient with several bruises in various stages of healing.
Various stages of healing. That is a classic textbook phrase you must watch out for on the exam.
What does that actually mean biologically?
Biologically, a bruise changes color as the body breaks down the blood. It goes from red to purple to blue, green, yellow. If a patient has a yellow bruise on their shoulder, a purple one on their rib, and a fresh red one on their thigh.
It means it's happening repeatedly.
Exactly. Injuries are happening repeatedly over an extended period of time. It is a major clinical indicator of ongoing systematic abuse. You cannot just assume the patient is clumsy.
You report it immediately. It seems like a really good rule of thumb for this entire exam is this. If an answer involves keeping a secret from the nurse, or doing nothing, or assuming things will magically get better, you should cross that option out immediately.
That is an excellent memory aid. Secrecy and inaction are almost universally the wrong answers in frontline healthcare.
All right, let's shift gears to Section 4, patient rights, autonomy, and ethics. We just talked about protecting their physical body, but we also have to protect their rights as an autonomous human being.
Right.
Let's start with some foundational ethics. The material asks which statement best reflects the ethical principle of beneficence.
Beneficence. That's a Big fancy word.
It is. The core of it means acting with the intent to help and benefit the patient in all activities.
Exactly. But let's look at the distractors, because they highlight what beneficence is not. One distractor suggests prioritizing speed and efficiency over patient comfort.
Which is so tempting when you have 12 patients in 45 minutes before your shift ends.
It is. Efficiency is great for your workflow, but it is not the primary ethical goal. Beneficence means the benefit to the patient comes first. If a patient is in pain and needs you to move slowly during a transfer, beneficence requires you to move slowly, even if it puts you behind schedule.
Another distractor says only providing care when patients are cooperative.
Right, which places conditional limits on your care. You have an ethical duty to help, even when patients are difficult, confused, or totally uncooperative.
Let's talk about the philosophical flip side of that. What happens when a patient doesn't want your help? This brings us to autonomy. Autonomy is respecting a patient's right to refuse care.
Autonomy is the right to self-determination. It's the recognition that the patient is the ultimate boss of their own body. Even if you, acting out of beneficence, know that a bath is incredibly good for them, their autonomy means they can still look you in the eye and say no.
And that tension between wanting to do good and respecting their right to say no, that is where refusal of care scenarios get incredibly tricky.
Oh, definitely.
Let's look at a case study. A patient has dementia and refuses a bath. The correct protocol is to inform the nurse and try again using different approaches or at a different time.
Yes. Dementia adds a massive layer of psychological complexity here. The patient still retains their fundamental right to refuse, but their refusal might be based on temporary confusion or environmental overstimulation.
Like the bathroom being too cold.
Exactly. Or too bright. Or just fear in that specific fleeting moment.
So forcing the care, literally holding them down to wash them, is completely out.
That is physical assault and battery. It's a crime.
But skipping the care entirely without trying again is negligent, right? Like, oh, well, they said no. Guess they don't get a bath this week.
Exactly. That abandons your duty of beneficence. And threatening punishment, saying, if you don't let me bathe you, you get no dessert, is psychological abuse. The best ethical approach is to back off, reduce their anxiety, report it, and try a gentler approach an hour later.
But what about medications? Because a bath is one thing. What if a lucid patient outright refuses to take their medication?
The answer is to report the refusal to the nurse immediately.
But wait, the distractor here says assume the patient will change their mind and try again later. Why is that wrong? We just said to try again later with the dementia patient's bath. Why is the rule different for a pill?
Because the underlying mechanism and the stakes are entirely different. A bath is a hygiene task. It's rarely a minute-by-minute life or death necessity. Medication is a highly precise, time-sensitive clinical intervention. If a patient misses a dose of beta blockers for their heart or insulin for their diabetes, the nurse needs to know immediately to assess the clinical impact. The nurse might need to call the doctor to alter the treatment plan. You can't just pocket the pill, assume they'll take it in an hour, and walk away.
The stakes and the timing, that makes perfect sense. Okay, let's look at a really extreme refusal. A patient asks you to help them leave the facility without medical clearance, leaving AMA against medical advice.
Right.
The protocol is to inform the nurse immediately and follow facility policy.
Yes, they have the autonomy to leave. Hospitals are not prisons.
But I want to argue with this. Look at the distractor. Call security to physically prevent the patient from leaving. I know you said hospitals aren't prisons, but if a patient is on IV antibiotics for a severe infection and they pull their IV out and say, I'm going home, they might literally die.
It's terrifying to watch.
Right. My beneficence screams at me to stand in front of the door and block them. Why can't I stop them from making a fatal mistake?
Because what you are describing, legally speaking, is false imprisonment.
Wow.
It is terrifying to watch a patient make a terrible, potentially fatal choice. But autonomy means a cognitively intact adult is legally allowed to make choices you strongly disagree with. They are allowed to make bad choices.
So what's my job?
Your job is not to act as a bouncer. Your job is to inform the nurse immediately so the medical team can intervene, explain the risks clearly, and if the patient still insists, execute the proper AMA discharge paperwork. That protects the facility legally from the consequences of the patient's bad choice.
It's a bitter pill to swallow, but it's the law.
It is.
Let's shift to dignity and culture. Protecting a patient's dignity is paramount. The material asks which action best demonstrates respect for patient dignity. The answer is using privacy curtains and draping the patient appropriately during personal care.
This is a huge factor on the physical skills exam, by the way. Always pull that privacy curtain. Always use the bath blanket. Do not expose their body to the open room unnecessarily.
And what strips away dignity? Discussing their info in public, obviously. But there's another distractor that I see happening all the time in the real world. Addressing the patient by their first name without permission. Like calling an 85-year-old retired school teacher Jimmy or Sweetie or Honey.
Right. It might feel friendly or affectionate to you. You might just be a really warm person.
Yeah, exactly.
But to an older adult who is already feeling stripped of their independence by being in a facility, having a 20-something caregiver call them honey might feel incredibly condescending. It could be infantizing.
So what's the rule?
Always, always start with a formal title, Mr. Smith or Mrs. Jones,
Right.
until they explicitly invite you to use their first name. It's a basic mark of respect for the life they've lived.
And speaking of respect, we have to talk about cultural respect. When working with a patient from a different culture, the protocol is to ask respectfully about their preferences and communicate with the nurse about accommodating those needs.
Culturally competent care means recognizing that your worldview is not the default. Not everyone views modesty, diet, eye contact, or family dynamics the same way you do.
The distractor here says, only follow the healthcare facility's standard practices without accommodation.
That rigid, cookie-cutter adherence completely ignores the patient as a unique individual. If you have a female patient whose culture strictly requires a female caregiver for intimate bathing, or a patient whose religion dictates specific dietary restrictions, you do everything in your power to accommodate that.
Yeah,
That is person-centered care.
that is so important. All right, let's move into section 5 of this deep dive. I pay, boundaries, and professional communication. Part of honoring dignity is how we speak to them and how we speak about them. Let's talk about I pay. According to patient rights, which information about a patient is confidential?
All of it. All patient information, including health status, treatment, and personal details.
All of it, not just their specific diagnosis.
Everything. Even the simple basic fact that they are currently occupying a bed in your facility is legally protected information. If someone calls the front desk and says, "Hey, is John Doe there?" you cannot confirm it unless that caller is on an explicitly approved list.
Here's a great real-world test of this from the material. You are walking down the hallway, and you overhear a patient disclosing personal health information to a visitor. You weren't snooping, you were just walking by. The correct action is to respect their confidentiality and not repeat the info.
Right. You didn't read it in their official chart, you just overheard it.
Yeah.
But the source of the information doesn't matter. It's still legally protected. You don't run back to the nurse's station and gossip about it.
But look at this distractor. Tell the visitor that they should not discuss the patient's health information in the hallway.
Yes. The impulse to be the hypea police.
Right. Excuse me. Keep your voice down. We have privacy laws here.
It sounds like you're enforcing the rules. But policing a patient's conversation with their own chosen visitor is massively overstepping your bounds. It's their information. They can shout it down the hallway if they choose to. The safest thing for you to do is just keep your mouth shut, keep walking, and respect the privacy of what you accidentally heard.
And Cert Prep Academy's modules on IPA are really great for this, by the way. They break down these communication scenarios really clearly.
I really do.
What about when family members actively seek you out? A family member walks up and asks you, "Hey, what was my mom's blood pressure today?" Or, "Did my dad have a bowel movement?"
The appropriate response is always to refer the family member to speak with the nurse or physician.
Even if I know the answer. I took the blood pressure. I know it's 120/80. Why can't I just tell the daughter and save everyone time?
Because you do not know the legal dynamics of that family. You don't know who has legal authorization, like a medical power of attorney, to receive that information. The patient might have explicitly requested that this specific daughter not be given medical updates.
Oh, wow. I didn't think about that.
Right. The nurse handles those authorizations, you politely deflect, and you certainly don't use your own judgment to share info just because the family member looks trustworthy.
Okay, let's look at setting boundaries and tricky conversations. This is where the rubber really meets the road. A patient asks you a medical question about their condition. Are these new pills going to make me dizzy? And you don't know the answer.
Honestly, tell the patient you don't know and refer them to the nurse. It is always okay to say, "I don't know." It's a sign of professionalism. It is never okay to guess.
And you shouldn't just abruptly change the subject, right? Like, "Oh, look at the weather outside."
No, because that's dismissive of their very real anxiety. Be honest. Validate their concern. That's a great question about your medication, and then connect them with the nurse.
Here's a tough scenario regarding conflict. You notice a visitor giving a patient food that directly conflicts with their dietary restrictions. Say, someone brings a box of sugary donuts to a patient on a strict diabetic diet. What do you do first?
The correct action is to politely explain the dietary restriction to the visitor and then notify the nurse. This requires serious interpersonal tact.
Because the distractor says, immediately take the food away from the patient, and my beneficence is screaming, that donut is poison! Snatch it away!
Imagine how aggressive that is. You just march into the room and physically snatch a donut out of a grown adult's hand.
Yeah, that's a very quick way to start a physical altercation.
Exactly. You escalate the situation to an 11 immediately, and another distractor says, report the visitor to administration for breaking rules.
The nuclear option?
Right. The visitor probably isn't trying to harm the patient. They just brought a treat and didn't know about the restricted diet. Education is the first step. Politely explain the risk and then loop in the nurse.
Speaking of altercations, what do you do when a patient becomes angry and yells at you?
Remain calm, speak respectfully, and report the incident. De-escalation is a crucial survival skill.
If you yell back to defend yourself, you completely lose your professionalism.
Right. And if you tell them to stop being difficult, you invalidate whatever underlying fear or pain is causing their distress. Stay calm, set a boundary, and step away.
What if it escalates further? A patient becomes aggressively and verbally abusive toward you, calling you names, swearing.
You calmly inform the patient that the behavior is unacceptable and notify the nurse. You're allowed to set personal boundaries. You're not a punching bag.
Yeah.
You can say, Mr. Smith, I am here to help you, but I cannot allow you to speak to me that way. I'm going to step out for a few minutes.
But look at this distractor. Leave the patient alone for several hours as punishment.
You cannot put a patient in timeout. That is medical neglect. You step out to de-escalate, but you immediately inform the nurse so care can continue safely.
And the other distractor, physically restrain the patient to prevent further outbursts. That is, assault, plain and simple. Physical restraints are only for extreme, immediate physical danger, and they require a strict doctor's order. You absolutely cannot tie someone down just because they're yelling at you.
Absolutely not.
Okay, what about our own internal emotional boundaries? What does it mean when a nurse aide maintains professional boundaries?
It means limiting relationships to professional caregiving and not becoming overly involved in their personal lives.
You care for them, you care about them deeply, but you are not their personal friend. You don't hang out at their house on weekends after their discharge. You don't accept expensive jewelry as a thank you gift.
Precisely. But there is a distractor that says maintaining boundaries means refusing to show empathy.
Oh, that's completely wrong.
Absolutely wrong. You can be deeply empathetic, warm, comforting, hold someone's hand while they cry, while still maintaining a firm professional boundary. Empathy is required for healing. Enmeshment, blurring the lines of the relationship, is prohibited.
You know, you can see how all these boundary questions, the high-pay questions, the conflict questions, they all weave together. They all connect back to just keeping the nurse in the loop and staying in your professional lane. Which brings us nicely to our final section, Section 6. Safety, infection control, and the written record.
This is the physical side of keeping everyone safe.
Right. Let's start with the absolute basics. What is the importance of accurate hand washing?
It prevents the spread of infection and is a fundamental, non-negotiable responsibility.
Hand washing is the MVP of healthcare, but the distractors try to trick you. One says, wash only when visibly dirty.
No, you cannot see diff, spores with the naked eye. You cannot see MRSA. Your hands might look perfectly clean and be teeming with lethal pathogens.
And then there's a massive trap distractor. Hand washing is optional if the aide uses gloves.
This is a critical misconception. Gloves are never, ever a substitute for hand washing. They are an added layer of protection, but microscopic tears in the latex happen all the time without you noticing. Furthermore, contamination during the doffing process, taking the gloves off, is extremely common. You must wash your hands before you put the gloves on and immediately after you take them off.
And the material proves that point with a scenario. You are assigned to make an occupied bed. When should you wash your hands? The answer is before the task and after the task.
Washing before the task protects the vulnerable patient from whatever microbes you brought into the room. Washing after the task protects you and the next patient from whatever you just touched in that bed.
What about bigger infection control? Caring for a patient with a communicable disease. You use appropriate protective equipment and follow isolation protocols. Pretty straightforward. But look at this distractor. Wearing protective equipment in common areas even when not with the patient.
Like wearing your isolation gown and yellow gloves down the hall and into the break room to grab a coffee.
Yes. Which sounds insane, but people get busy and they forget to take it off.
And I have seen it happen in real facilities.
Ah.
That completely defeats the purpose of isolation. The PPE is covered in pathogens. If you wear it out of the room, you are acting as a delivery service, spreading the disease everywhere you walk. You take the contaminated PPE off before you cross the threshold out of the room.
Let's talk about your own physical safety. You have a patient with mobility limitations who asks for help walking down the hall. But your back has been hurting all day. What should you do?
You must use proper body mechanics and ask for help from another staff member.
Protecting your back is vital to having a long career. Don't try to power through and risk a worse injury just out of pride. Ask for help. Two-person assists exist for a reason.
Absolutely.
Now, what happens when you are just completely bone-wearingly exhausted? The material asks, a nurse aide is tired after a long shift and makes a careless error. Which statement best reflects the aide's ethical responsibility?
The answer is that patient safety is always the priority, regardless of the aide's fatigue level.
We're all human. Fatigue is a very real reality in a 12-hour shift. But fatigue does not legally or ethically excuse careless errors. You are always fully accountable for the care you provide. If you are genuinely too tired to perform a task safely, you have a professional responsibility to ask for help, or consciously slow your brain down to double-check your work. You can't use exhaustion as a get-out-of-jail-free card.
Which leads right into documentation and reporting mistakes. What is the primary purpose of documentation? The correct answer is to create an accurate record of patient care, observations, and responses for continuity of care.
Continuity of care. I think of documentation like a relay race.
Oh, how so?
Well, imagine a relay race, but the baton you are passing to the next runner is made of incredibly fragile glass. When your shift ends and the next shift comes on, they rely entirely on your written notes, that glass baton, to know exactly what happened over the last 12 hours. It's the ongoing story of the patient's day. If your documentation is sloppy or missing, you drop the glass baton. The entire race falls apart and the patient pays the price.
That is exactly right. But look at a common cynical distractor here. The purpose of documentation is to avoid being blamed if something goes wrong.
The old CYA, cover your assets.
Right. A lot of people cynically think charting is just legal armor. And while accurate records do absolutely protect you legally, that is a secondary benefit. The primary driving purpose is always clinical communication for safe, seamless care.
Okay, here is a classic exam trap. I call it the secret trap. A patient requests that you not tell the nurse about a fall that just occurred in their bathroom. What do?
You immediately report the fall to the nurse, even though the patient requested secrecy.
Falls are incredibly dangerous. Let's walk through the reality of this. A patient slips, bumps their head, gets up. They feel totally fine in the moment. They are deeply embarrassed that they fell. So they look at you and say, please don't tell the charge nurse. She'll make a huge fuss and call my daughter.
And if you agree to keep that secret, they might have a slow subdural hematoma, a brain bleed. Hours later, while you're sleeping at home, they could slip into a coma and die.
So safety is always, always greater than secrets.
Always. You cannot keep secrets that impact medical stability. You have to look at the patient and gently say, Mr. Smith, I am so sorry, and I know it's embarrassing, but for your safety, I am legally required to tell the nurse so they can check your vitals.
What if you are the one who makes the mistake? A nurse aide accidentally delivers a meal tray to the wrong patient that had someone else's pills on it, but they realize the mistake before the patient actually swallows the pills or receives any harm. What should the aide do?
You must report the error to the nurse immediately.
Even if there is no harm, the patient didn't eat the pills, why do I have to tell him myself?
Because near misses are the most valuable data points a hospital has. They must be reported because they highlight underlying system failures. Maybe the meal trays are labeled poorly. Maybe the lighting in the hallway is too dim. If you report the near miss, the facility can fix the root cause before real fatal harm happens next time. Hiding it is negligent.
Yeah, documentation questions are everywhere on the Cert Prep Academy practice test. They love testing you on these what if I make a mistake scenarios.
Because it reveals your true professionalism. When the chips are down, will you protect your own pride or will you protect the patient?
Wow, okay. Let's take a deep breath and recap this massive journey we've been on today. We talked about staying firmly inside your scope of practice, driving the sedan, not flying the helicopter. We covered the absolute necessity of communicating up the chain of command, whether it's a subtle observation or a coworker sleeping on the night shift. We drilled down on protecting patient dignity and honoring autonomy, even when it's agonizing to watch them refuse care. And we wrapped up with infection control and being the guardian of the glass baton with accurate documentation.
It is an immense amount of responsibility,
hmm
but it's also an incredibly noble, vital profession. You truly are the foundation of the entire system.
And speaking of foundations, we need to acknowledge something huge. Throughout this deep dive series, we've been building your foundation. If you are hearing my voice right now, you have successfully navigated all 11 parts of this series. You have conquered the entire NNAAP syllabus. You know this material. You have put in the hours.
You really have. You've done the hard work, and it's going to pay off. But if I can give you one final critical action item before your test day, the absolute best way to lock in everything you've just absorbed, to test that foundation under pressure, is to go practice it right now while it's fresh.
Yes, and that is exactly why certprepacademy.com exists. It is completely free. There is no sign-up required. You don't have to put in an email or a credit card. You just click and go.
They have a 70-question practice test that mirrors the real NNAAP exam.
Plus, free study guides covering every single topic on the test and flashcards to help you lock in those key terms. Everything you need to pass is in one place, and it costs nothing. Head over to certprepacademy.com. The link is in the description.
We believe in you. You have the knowledge. Now just go prove it to yourself.
So, as you head into that testing center, I want to leave you with one final provocative thought. We live in an era of rapid technological advancement. In the next 10 or 20 years, we're going to see AI and robotics start taking over huge swaths of diagnostic medicine and charting. Machines might soon be reading the wound beds or dispensing the meds, but the one thing a machine can never, ever replace is the human empathy, the gentle touch, and the ethical boundary setting of a dedicated nurse aide. As you step into this role, ask yourself, as technology changes the building, how will you evolve the definition of patient dignity in your own daily practice?
That is a powerful question to carry with you.
Remember that you are the mortar holding it all together. Be incredibly proud of that. We wish you the absolute best of luck on the NNAAP written exam. Go crush it.